Good morning, everyone, and welcome to this webinar, which I think will be extremely interesting. Actually, this webinar is part of interactions between our I3h Institute and the Kick Cancer organization that many of you may know very well. It's a remarkable organization which has been set up by Delphine Hennen and which is now recognized in Belgium as a major player for the advocacy of developing new approaches for pediatric cancer. And it's been a pleasure to see the advances made by Delphine and her team during recent years. And among the important developments that Delphine was able to achieve was to create a team around her, and also to involve more people passionate as her for actually the same reason, by the different issues related to pediatric cancer. And actually, Sam Daems, who is our speaker today, is indeed one of the closest collaborators from Delphine, and actually he is working on a team on teams which are very close to what Matthias and Hilde are trying to develop in the context of rare diseases in general. So I will not make this introduction longer. I would like to thank Sam for being with us today, and perhaps Delphine could say a few words to introduce Sam. Thank you.
Thank you, Michel, for the kind words about cancer. I had the pleasure to meet Sam for the first time at the Belgian Post, which may seem odd, but we were working together as consultants for Bain & Company on a project for bpost. So we have nothing to do with the current news about the Post, but we were trying to help them get ready for the 21st century, which they haven't really completely done so far. But anyway, Sam struck me immediately as being not only kind and incredibly clever and fast. He would really, build reasonings in the nip of a second, which is always very impressive when you get to meet someone. And our ways parted. I left Bain, so did he, but our path crossed again for unfortunate reasons, because we share the misfortune of having a child with cancer. And I had a tea with Sam and his wife shortly after their daughter Faye passed away. My son was at that point in time relapsing from a soft tissue sarcoma, which he's still battling with. But so pediatric cancer was our common problem, and also great motivation to make the world a better place. And that's how we started thinking about how can we do something about that, beyond the stage of making people cry, beyond the stage of lamenting on this, really trying to think about tangible solutions that would have helped our child, but also will help future children by putting systems in place to speed up and generate more innovative treatments for children with cancer, to cure them in greater numbers, but also improve the way they are cured, because today we keep on using old drugs that have negative side effects for those who remain alive. So with these words in mind, I want to hand over the word to Sam, who will present his approach, which is definitely a game changer for what we want to achieve.
Thank you very much, Sophie. Thank you very much for having me here today. It's quite a big honor to be in this audience today, and it's a big honor because there's also a bit of expectation management. I am, and I must admit that humbly, not an economist, and I am not a healthcare professional. But as I've indicated, due to a personal event, I am, however, quite interested in the space. Thank you very much. And so my background, the trigger for me for being here, the trigger for me for investing time and energy in the domain is the very sorrowful event which Delphine already alluded to, which is the fact that our family unfortunately lost our daughter to very, very aggressive tumors in 2020 and 2017. At that point in time, our girl was 2 years old when she was diagnosed, and 6 months later, unfortunately, she passed away from the disease, and we really never really had a decent chance of beating the illness. And so with this event in mind, I started to read into the space and started to try to understand what had happened to us and why it had happened to us. And of course, in everything in life, it's your perspective and your starting point defines a bit how you look at a problem or how you look at a situation. And my perspective is a business perspective, because over the past 15 years, I've been active in a business context, like Delphine already indicated. I started my professional life at Bain & Company, which is a management consultancy firm, then moved towards a big industrial conglomerate where I headed the business platform, always solving problems, transforming things, trying to improve things. And for the past 7-8 years, I've been working at a private equity investor, Waterland private equity, a European investment fund, which manages 15 billion euros assets under management, trying to create value for ourselves. So everything which I look at, if you're a hammer, everything looks like a nail. So if you're a private equity investor, everything looks like a capital structure which you need to optimize. And so that's a bit also the lens with which I looked at pediatric oncology space. And that's also what I would love to talk to you about today. And so the agenda for today will start a bit on a quick excursion in pediatric cancer and why it is such an annoying problem which we need to resolve, to then take a step back and talk about a few concepts or ideas which could help us, which could be tools in the toolbox towards a potential solution, to then combine some of these ideas into our working hypothesis, which Delphine and I and the team are working on, which is more of a pooling of different capital sources in a model which can create leverage and which can catalyze change in space. And I would love to spend a bit of time on the discussion as well, because this is a working hypothesis and it is far from mature, so it is still thinking, and we're discussing with a lot of stakeholders and a lot of actors in the space, but your combined intellect will undoubtedly be of extreme value for us. So please speak up, because the concepts need to be refined and sharpened before they can be put in practice. And so your input will be massively valuable for that. But let's start with having a quick look on pediatric cancer. I don't know how familiar you are with the space, but although pediatric cancer is rare, it really remains a major cause of suffering, and it really remains a problem which requires all of our attention. And in total, every year, around 35,000 families will have a child or a young adult which is diagnosed with cancer, and of these 35,000, around 6,000, a bit more than 6,000 will die every year of their disease. So there is quite a lot of suffering associated to the illness. And the children who are lucky enough to survive and who continue their journey not only are burdened with the history of their disease, or burdened with the risk that it might come back and that there might be a relapse, but typically have been confronted with a very aggressive therapy, which also has late effects, which also has impacts on their cognitive powers, on their mental well-being, on their future. So it's not because you're cured, it's not because you don't die that you're cured and that's it's in the past. It continues to be with you. And secondly, if you look at the statistics, these are survival statistics on a 5-year basis based on UK statistics, which is quite comparable and relevant, I think. If you look at the different types of tumors which are in there, the statistics vary widely, and if we then zoom in on each of the types, each of these individual bars hides a lot of subtypes, which then again have an even broader survival statistic and even broader prognosis. So if you look at brain tumors, which is of course I know best because my daughter died of a brain tumor. The chances go from 99 to 22, and unfortunately, my daughter was in this bucket bottom. She was diagnosed with ATRT. So from the second that she was diagnosed, we knew that she would have a very tough situation and that she would probably never survive. And if she survived, that terrible future. So this is the reality which we're confronted with. And there has been progress. Luckily, there has been progress, but progress is kind of stagnating over the past years, and progress has been based a lot on very aggressive patient therapeutics. therapeutics which have been developed in the 50s, 60s, 70s of the last decade, the last century, which have their effect, that they stop and they limit the disease, but which also have a lot of effect on other developments of the child. And of course, the child, especially if you're a younger child, below 5 years old, you're evolving so rapidly. If you then use these aggressive chemotherapies, radiotherapies on the child, there will be side effects and you will have problems with it. And so just as an illustration, I know it's anecdotal and I know it's worth nothing, but this is the protocol which my daughter or our daughters went through. It has a combination of 9 different chemotherapies every 3 weeks, injected with 3 chemotherapies, very, very aggressive. Each of these things is a very aggressive poison, which is injected in her body, combined with radiotherapies after each instance. So it is extremely aggressive. And even if she would have survived, her mental cognitive power would have been frozen at the state of a 2-year-old. She would have never developed a normal life. She would have had hormonal deficiency. She would have had a terrible, terrible future. And so this is the reality, and it's a rare reality. Yeah, luckily, let's be very, very thankful that this is a rare disease and it doesn't happen. But it is unfortunately the reality which we're faced with, and it hasn't evolved that much or less than we would have wanted to, despite the fact that everyone around us agrees that this is unacceptable and that we should help these children, that we cannot accept the suffering. And this has a massive societal burden. It not only hits the family that's confronted with it, but it's the entire economical system around it. It's the entire social system around it. And every child which is diagnosed has an impact on the father and the mother, which will probably reduce their economic contribution in society, which will be unhappy, which have a lot of problems. Everyone agrees. Everyone you talk to is committed to make change. And so I'm a strong believer that everyone in the space, in this room, but also at Roche, which is the market leader in oncology and pharmaceuticals, or at VC firms, everybody would love to change this, but still not a lot's happening. And so that kind of brought me to the question, when is it exactly that a project attracts economic?
Sorry for stupid questions. So,
Yeah.
So the new drugs are really different from these treatment?
Yes.
And what prevents finding them children?
So you look at the different categories of drugs. You have the chemotherapy and the radiotherapy, which are the historical ones. You have surgical, so physically taking away the tumor.
You said 150 new drugs.
The first one, look at the new drugs which are up here. They often have a modern targeted therapeutics. So they will target a specific pathway, chemical pathway in the disease, and they will stop it.
What prevents applying these treatments or the logic of these treatments?
Academically, nothing. Economically, a lot. And that's exactly what we would like to talk about today. So why is it that these therapeutics are not finding their way to the clinical world? It is because the decision to invest in such a project, to test the molecules and to test the therapeutic on a specific target for a pediatric or for any indication is made on an economic basis. And economic basis, these are slides. When I started to look into the space, I encountered these beautiful internal slides from Roche, which were public, where they explain to their stakeholders how they decide to invest in a pediatric oncology project. And so it's basically an NPV calculation, and the way you would do it and started to invest it, the way I would do it at Waterland when investing in a company, we will look at IRR, at NPV, at different return metrics. We will look at these metrics and we will put them in a beautiful 2x2 and say, okay, this is the hurdle. So that is what I minimally need to get to be willing to invest in this space. And then I will start from the most attractive and move down and see if my capital ends up. If I have 100 million, I might only do one. If I have 500 million, I will do 5 of these trajectories, and I will select them based on the economic value of the project which I'm investing in. And that's where, to answer the question, it becomes difficult for pediatrics, because pediatrics inherently have a few characteristics which are very difficult to put them into a standard pharmaceutical economical viable project, because populations are typically very small. The 35,000 patients which we've noticed, which we talked about earlier, they are spread across 100 different types or subtypes. So ADRT is one of those 100 different types. And each population is relatively small, and especially, that of course, not by coincidence, bigger populations have it easier to attract resources because the market is bigger, because the potential is bigger, because the suffering is bigger, if you want to stay from societal value point of view. And so they are able to attract interest. And that's also why, if I skip back a few pages, if you look at this slide, things like leukemia, certain leukemias which are very present in children and which have a big high incidence, those disease areas have attract a lot more attention, attract a lot more projects, and have better protocols, better statistics in the end. That's how it works. Whereas ADHD, what my child was diagnosed with, there are two to three children every every million child years between 2 and 5 years old. So that's very low incidence. It doesn't happen. So why spend time on it? Why spend energy on it? Why spend money on it? Unless you're the person who got that ticket, the 2 out of 1 million, and you say, "Yeah, why don't we spend money on it? We need to help my child." And so that's a bit the thing with statistics, right? Statistics are great, but if you're the 1 out of 1 million, then you're stuck with it, and then you need to cope with it. And so again,
Sam, sorry to interrupt you. We have a problem with the sound. We cannot hear you well, and I got several messages through the internet. So could you try to speak closer from the microphone? And I don't know. Thank you very much.
So where would you like me to put it? Do I need to put it here?
And if you stand right next to it, it should be okay.
Okay, I'll stand right. Can I hold it in my hand?
Also,
Or will it be? Let us try this. Let us know if it doesn't work, Professor. Is this better?
It seems better.
Okay,
anyway, I'm in contact with other colleagues on the internet, so I hope they will confirm it's better.
Okay,
They say it's perfect now.
Let us know if it doesn't work out. Apologies.
Thank you, Sam. Sorry for interruption.
No, thank you for helping out. So the question which we then have, if you come to this conclusion, is if this is the reality, and that's a bit the point of my entire presentation, I accept the economical reality in which we work in. So I accept the capitalistic fundamentals of what gets invested and what does not get invested. But the question is, within those boundary conditions, if you accept the capitalistic world in which we live, what can we do to get more projects funded, but more importantly, to get more children helped? That's the base question. And so based on this question, there are a few things, and they will come back in the model, which we will discuss later, but a few theoretical concepts. Of course, we can improve the returns on an individual project. Why don't we improve the returns? And so if you look at what drives the returns, one is the population, the market share, the addressable market for your specific molecule or product. What is the revenue I can get in the future? Populations, luckily, we will not, I hope that nobody has the intention to increase the number of illnesses in Europe. That would not be recommended, but there is, of course, a market share question, which you can see. There's an adoption question. How do we accelerate that our molecule or our therapeutic is being used in the clinical wards? There is a very complex discussion today on what is the right pricing. Is it okay to price a drug €1 million per therapeutic, €1 million per injection? Do we accept that as a society? Yes, it saves the child, but is this something which we want to pay back? Is this something? So there's a lot of discussions on pricing. There's a lot of complex discussions around availability, especially within Europe. Do we want to demand the molecules to be available in all markets? Probably yes. But how does this impact the price? How does this impact the development trajectory? So it's a complex site, but the revenue potential in the future is, of course, one of the key drivers. Other key driver is the development costs. And there on the development costs, if you look at the left-hand side is Roche's internal document, which is US-centric. The right-hand side is a European Commission's document, which explains over the past 10 years what the typical costs were for a pediatric investigation plan. And so you see that the averages are relatively okay, but the complexity here is this huge standard deviation. If you look at a phase 2 or a phase 3, the median cost to run a phase 3 pediatric clinical trial is 1.5 million. The average cost is 50 million because the standard deviation is 22 million. So there's a huge gap between the different, a huge difference between the different projects which are run. Very interesting field to investigate what
drives this gap. And I don't think the audience is going to understand, so I have a question from the public.
You're jogging on the way. So why don't you have off-label prescriptions that would allow you to naturally experiment with these new drugs?
You have. That happens quite a lot, but that does not result to a market access, and that does not result to economical project which index.
Learn a lot about the expected cost of developing.
You can learn a lot, and there are a lot of programs today. Let me give you an illustration. There is a program which I love. It's the SASHA program, which you know very well, Delphine. It's a program which tracks off-label use and which then distills statistics out of the off-label use to see which therapeutic works on which target, which then tries to take the next step and understand, okay, if the system says, yes, there is a reaction, what could cause this reaction, and which then ultimately will create a project, a clinical trial, which pushes this specific molecule into the standard of care.
So when they look at these distributions, you should learn about the shape of distribution and therefore be able to.
Correct.
You should have incentive to develop drug when you learn.
Correct, and that's exactly what we're going to come with later. If you want to reduce the cost in the model, which we're going to present a bit later, this is one of the elements which is in there. Use the data generated by academia and use the data generated from off-label use to drive this, which is not happening today that often, but I'll explain later in the documents. So let's quickly skip through these ones. The development time is also pretty important, of course, especially in today's 5 years ago, it was less valuable because there was not that much time pressure because inflation was low and reference interest rates were low. Today, inflation is going up again and reference interest rates are going up. So the time value becomes even more important. Oncology projects typically last 10 years from phase 1 to market access. So that's quite a long time. How can we accelerate this? How can we compress the phases? And we'll come back to an element in the model, how we could do this as well. And then the big impact is the probability of launch. And this is very interesting. On average, oncology has a 5% success rate. So a project which is started, 5% of these projects end up getting a market access. So that's 1 in 20. If we zoom in on a few specific therapeutics, and I think the professor was discussing to this earlier, CAR-T, monoclonal antibodies have a much higher success rate. And this is, I think, is hyper interesting to understand and to work on, because to me, the 5%, which is today accepted as average for oncology, is probably an underestimation of success rate, because this 5% includes all projects which have been launched, but also projects which have been launched for very big markets. So colon cancer there, it's acceptable to launch a project which has a low success rate, where you know upfront, chances of getting there is probably not that high, but if we get there, then we've got a 2 billion blockbuster drug per year. So yes, of course, that makes total sense to investigate such a project, because the returns are high and you're accepting the risk. Whilst if you look at these CAR-T and the monoclonal antibodies, the costs of executing the trial is so high. In your system, you will have actually need to execute these trials on a global basis, and the probability of launch is as uncertain as any other project. So if we map that in a matrix, the chance of getting something approved for a very small population and for running through all the steps of a clinical trial for small populations, it's not that easy to do in the standard economic system, because you will need to be very convinced that your project is going to work, and you need to be very conscious on the costs or else this is how every PC will look at a project which is finances. This is how every pharma company will look at a project which is finances, and there's probably nothing wrong with the way it works, Professor.
Well, the one thing, one additional idea could be, look, you start with this economic model. What if, for example, without changing anything else, if instead of the CEO of Roche being in charge and talking to the shareholders, mostly, what if you and Delphine were in charge of this company? Would that change a lot? Knowing that you cannot go bankrupt, okay.
I think it would. I think there is a model which, if you do not have the for-profit incentive as the basis of your optimization problem, because that's what they have. They have a for-profit. They have a constraint problem, and they want to optimize a parameter, and the parameter that which they are optimizing is their cash generation on longer term. If you do not take that as a base constraint, as a base target, but you replace it with a target which is help as many children as possible, then even within the economical system, it's my belief that there is a model possible. And that I'm going to skip through a few slides very quickly, and then we will see how it works.
I'm not saying that you will receive the whole budget of the government and then you do what you can. It's
No.
still need to be, you have a budget and you need to survive with that budget. But you don't try and maximize shareholder value.
Yeah, correct. And so let's click through that, and we'll come back to it, because that's the core actually of the new model which we're referring to. It's very interesting that you say that. Another question back.
I have a hard time believing these graphs. If you look at the financial reports of these companies, the rare disease subsidiaries, or well, anyway, the units actually more profitable than the rest.
Correct. They benefit a lot from the regulatory setup, which allows it.
Exactly. So, frankly, these matrices, which are just the size of the market, etc., it seems to me to be more a marketing thing to beg more money than a market reality.
I think I would let's look at the economics later on.
I'm thinking exactly like that. Okay, and then I looked at what's coming out on the market, and it was complete clash with the kind of graphs which are.
We should maybe bear in mind that if you look at rare diseases, this is a really rare disease. Under 320 patients per year, it's really little.
Where most of the development is in these very, very rare diseases.
Okay, but let's compare notes then after the discussion. But I understand. Let's compare notes after the discussion, but it will not impact the rest of the discussion. I think park it for 1 second, and we can take it back in the end if you think it's relevant. So maybe one thing to improve returns, an illustration which I like a lot. There's nothing negative about this one, and it's a really cool business model, which is Day One Biopharmaceuticals. What they did in their model, they made the exact same analysis, and they said, okay, if you want to break out of this constraints, how can we do it? How can we improve some of these parameters which we discussed earlier? And what they did is they said, okay, the key differentiation is if you want to bring progress to the child, why don't we look at markets which have a child and an adult indication which can benefit from this disease, so that we extend the market and that we kind of subsidize the pediatric development by using the revenue potential from an adult market, and as such create a model which works. This is a for-profit model. It is stock exchange quoted. It has attracted capital, and it has just changed a few of the paradigms. They are buying existing drugs, so they are buying drugs which have a proven history. So they are de-risking a bit by taking more mature products and taking the last steps in a clinical trial setup. They are partnering with academia to execute these trials. But most importantly, they are using an adult-child combination, which allows them to address a bigger market, which makes it economically viable for them. So this is one illustration.
Can I?
Of course.
Along the same lines, but big, and therefore you need a kind of societal perspective. Some of this research in rare diseases can at times, and we don't know, but there is a probability that can also be helpful for really non-rare diseases. So I think it's Delphine who said at the end of March in our conference, the mRNA technology was developed in the case of rare diseases. So in that sense, there would be a reason for the authorities to subsidize these kind of things, take into account the probability it could be beneficial to, yeah.
Correct. I think that's great. That's great. I agree. And that's what should incentivize, because the government has a key role to play here to start such a model. But I'm gonna quickly click through a few pages. Increase the choice of projects. Of course, if we have more projects to choose from, then there are probably unknown projects out there which are not popping up on anyone's radar. So if you get them to pop up, a lot of them will be unviable, but some of them might be viable. And that's every project, to me, every dot here is a child which gets a cure. And 10 years from now, if you finance the dot, it means that 100 children will get a cure 10 years from now. So that's worthwhile doing. And to do that, I think Delphine and the team are working on that as well, trying to create a shared view on where the unmet needs are, taking the shared view on unmet needs and explaining and translating it into priority areas which are underserved and where there needs to be progress, and then taking these priority areas one step further and build a structural plan to improve progress in it, to create a community which works on it as a first step. Maybe not economically viable, but just get the juices flowing in the space.
I'm sorry to hijack this, that exists, right? You have
That
companies with artificial intelligence mapping potential drugs that may
Correct,
be
but this is even the step before that. So there are disease areas where there is no structured community spending time on investigating it.
It's not a community, they just take all the drugs, they simulate potential.
Correct, but which target are you going to attack before you do the AI?
It's like horizon scanning, they scan everything.
Correct, but somebody needs to indicate which targets you want to work on, right?
Yes.
And that's the step which comes before, and that's what the academic community does. That's what's missing today in some of the fields.
Okay.
And so before such a company like the one you're referring to can start its scanning and start its AI model and feed and educate the model to see what could work, you first need to know what target you want to address. And that's scientific evidence, which today is scattered around 50 universities across the world, and where the first step should be to bring them together and to bring these communities together to think about what is the problem. And once you know the problem, then you can ask the company which you're referring to come with a solution. But if you don't know the targets, you don't know the keyhole which it needs to fit in, you can't say whether you need a big or a small or which key you want to use. But the crux of the thing, and what I spent most time on and what I like best, is the last lever which we have, or the last topic which you can work on, which is reducing the cost of capital of such an organization which works on it. And that's very close to Professor, what you're indicating. And what if we drop the for-profits? What if we drop, if the CEO is not someone who is optimizing his stock option plan, but if somebody who is optimizing the societal value, what would it look like? And that has a massive impact, because just a small excursion into the impact and sensitivity on the cost of capital, the projects which you can fund are hypersensitive capital which you put into your model, hypersensitive. And this is just a conceptual illustration. It costs you 100 million euros. You have, if you look at the parameters, pretty much 100% certainty that you're going to get $10 million in this indication per year for the next 15 years. After 15 years, you probably get zero. But this is a project which you can finance. It brings societal value. You cure ATRT, which is it's a terrible disease. So this is a really cool project. But do you fund it when you rush, or don't you fund it? And the answer is, it depends. It depends on what your internal rate of return expectation is. Which return do you want to get? And depending on which expected return, which return expectation you put in your model, it ranges from a project which we must do and is going to generate $50 million excess return, to something which is absolutely stupid and is going to eat away the budget of my department and going to kill my bonus. And so depending on which return expectation you put into your NPV calculation, you're going to end up somewhere completely different. And that has a material impact. So we're now not impacting the individual projects, but we're impacting the hurdle rate. And if we take this hurdle rate and we push it back, we say, okay, we're now accepting a lower return. We don't need 30% IRR as a VC, but we need 10% IRR, or we don't need 20% as a Roche, but we accept 5%. you will create a lot of value, and this entire space, all the projects which are in that space will automatically become economically viable, and you can work on them and you can push them through the system. And that's the starting point which you've ended up with. So how can we now, the question, if you're at this point and if you're in agreement at this point, is how can we now create a structure which can suck capital out of the markets as much as possible, because we need a lot of money to fund all those projects, but at a low cost of capital. And when you start to look at it, there is one source of capital which has a very low cost of capital, and that's the philanthropy money. That's Kick Cancer's money. They don't need a financial return; they just want societal value. So their return expectation is minus infinite. They don't need anything as long as the children are safe. There's a government which has a massive societal value out of getting this done. Societal value within the field, but also the spillover effect, like you just indicated, Professor. There is pharma companies which are today more than ever pushed by us, by the public, to act responsibly and to take their social responsibility. So they have today substantial budgets, not millions, but tens of millions of euros every year, that they're willing to invest into projects, into structures, into elements which can structurally improve their societal value, and with their image and their marketing materials, you will say, but which can help their position. And so the idea is, what if we take all this money and we structure it into a capital structure? And that's what every day, and that's what everyone in private equity does. You build a capital structure which maximizes your returns. If we change it, turn it around, and instead of saying we build a capital structure which attracts as much capital as possible at the lowest possible cost of capital possible. And that's what we started out with. And if you compare that with what the pharma companies are doing, you come with a very different thing. Because if you look at the equation which you had before, pharma companies, the existing oncology specialists in the space, they have a very, very, very attractive economics, massively attractive economics. And if you're depending on where you are in your view and what your beliefs are, some people will say that these are excess returns, that they are getting too much, that they should not be getting that much return as a shareholder, that the economics can go down. Other people will say, no, this is completely ignorable. You need to have those returns because these companies are taking a massive risk. Because what we said before, the simple projects on I3h, this is the risk-adjusted expected cash flow, but as we saw before, there's a 5% chance of success of getting a project through to the market access. So actually, it's 95% of a chance you just put in 100 million and you don't get anything, and then there's a 5% chance that you will put 100 million in, but get 200 million euros every year as a return, and that leads to this risk-adjusted cash flow. So if you wanna take away this concern, if you want to take that away, there is a lot of scientific theoretical evidence today that a good portfolio structure takes it away. And that by optimizing your portfolio, you can reduce the risk at the same return. And so you can migrate towards or gradually converge towards the average return whilst narrowing down your standard deviation and making it more attractive. And it's these two elements. So how can we get a lower cost of capital by building a capital structure which is smart and still attract a lot of money, together with a portfolio concept, which is what we're working on today and what the working hypothesis is. And that is a pooled investment fund to finance this innovation through independent vehicles. And if we talk through it, what are the different elements? The base premise are the two elements which we just discussed. We're going to pool different sources of capital, philanthropical money, CSR money, and public investments. We're going to use this money to create an equity layer which accepts complete wipeout, which is okay with losing money or not generating any return at all. And we use this as a first loss structure to, on top, attract market standard private money from investors, from you, for instance, at some point, I hope. No, from anybody in the world who would want to invest in such a capital structure, and who would be willing to accept a relatively low return because the risk has been mitigated by this equity layer, which has a first loss. But secondly, the societal impact is very high, and there are quite a few family offices, institutions, generosity funds, which would be very happy to invest at a low return as long as there is quite a bit of societal value. So that's the first element. In order to do that, you need to be able to invest in something which has quite a predictable return. And to do that, you need to build a portfolio. And this portfolio needs to be independent from each other, because else if one goes down, they all go down. So you need to build an independent portfolio of different development trajectories, which can statistically spread the risk and which narrows the standard deviation while maintaining the average return so that you can pay back your debts. And to do that, to execute those trials, the model would like to work with a very smart way of executing trials to reduce costs and to reduce the time to come to a conclusion through an adaptive trial, which focuses on specific disease areas. And that's a bit the idea, to make it independent from each other. Every focus area could rally a team around this focus area, bring together the expertise and the ecosystem that has been working on this disease area or on this focus area in one community, which will then design and prioritize a trial which optimally allocates the time and energy and the patients to this one adaptive trial design, which instead of having 5 double blinds next to each other, have one reference group and have the different trial design based on statistics showing, okay, our hypothesis number 1 was this is the best drug, it works, it does not work. After 5 or 6 children, we say, okay, we've proven that it doesn't work. You need to move on to the next and just follow the decision tree, which is designed by science, and along the way, accumulate these insights, along the way, accumulate scientific intelligence to refine the further design of the trial, constantly adaptively adjusting the trial design. I'm going to finish this one with an flexible legal structure, which allows you to monetize the results, because the idea is to create something which brings progress, but which is also self-supportive and which shall continue to future. And we need to monetize the results because we need to pay back the capital, the debt, which we use to increase our total available funds.
So I fully agree with the objective. I'm trying to think about this similar idea.
Yeah.
And one of the...
Michael, est-ce qu'on peut te demander de parler dans le micro parce que quand vous parlez, on entend mal.
So the problem I see is that they already do that. You have all these small companies, medtech, not fintech, biotechs, etc., which are spin-offs from universities. They do exactly that. Okay, and then when they have an innovation that is close to market, it's the Google model, the Facebook model, etc. You need the access of this big pharma, and they can just poach you at expensive price, a few billions. But precisely as you say, they let the 95 go bankrupt, and they just buy the 5%. So the market is actually providing that,
correct,
but still allowing the big pharma to make the
what this one does is uses exactly the thing which you just say as a strength. Because what this one does, it's going to seed the portfolio is going to seed a lot of seeds in different.
So this is what we do.
It grows up, correct. Once one seed grows up, we will sell it to Roche for a lot of money, and the money will be defined at some point, and that money will go back, recycled into the fund to do the next wave. So it's using exactly that. What is the difference with this and the previous one is that this one, or with the standard that this one is going to get a lot of funding. It's going to get a capital structure with a low cost, which allows us to select not 1, not 2 individual spin-offs, but 50 different project trajectories, going to let them flourish. Unfortunately, a lot of them will die along the way. We are going to stop investing in them, but the ones that will grow up to an economically viable project, they will exactly be sold to Google, which is not Google, but which is Roche in this ecosystem. And we will get the proceeds from that sale to fund another 50 different structures.
My point is that you will always have to underprice the sale because they want their 25–40% return on equity.
Yeah, but that is correct. So in their calculation, that will be
the sales by a half. Basically.
There is another model in which you keep the assets and you keep the cash flows from that in the future. That's perfectly possible. Why it's possible. What you say is correct. I agree. The reason why we are choosing, or in the current working hypothesis, we're choosing to sell off the IP is to generate cash income, which can be used to repeat the model. And so for me, it's more important that the molecule reaches the clinical ward. And so I want to get the value of that bridged at the first steps. And then once it's viable, I would love to sell it off and get proceeds, get cash flows in, which allows me to seed others, slow seeds. And the thing is that I will get maybe 10 years of cash generation on day one, and else I will need to wait 10 years to get the cash. And so on the longer term, yes, you will get more cash, but it will take time to get the proceeds back, which you need to finance your next wave. And
you have a high discount rate.
I want to go fast. I don't have a high discount rate, not in the first wave. I don't do that.
But how do you want to make, how do you make sure that the drugs will not be sold at tremendous
That's a
prices?
discussion, and that's some of the discussions which we need to have at some point. And so let's see who is in this capital structure, but the way I would see it is that you have given the fact that in my mind, the European Commission is going to finance part of it, I would expect that they would impose certain limitations on the prices at the end point.
That will also impact
And that will
the
impact
price at which you can sell
Correct,
your.
but that's not necessarily negative. There are two things about it. On the one hand, yes, it's negative because you can't ask whatever you want, and economically it will ruin your model, but it creates, if the European Commission creates certainty on those prices, they go into the business model at the sales point of view, and you'll be able to sell a certain effect. And Europe is not necessarily the biggest market for a lot of drugs, and so we need to see. My correct answer is I don't know yet. We will need to see how this plays out, but it could be imaginable that if the European Commission funds this, that the European market has a price agreement which is defined, and that this price agreement is not necessarily applicable to other markets, but we'll need to see how it works there.
Well, then you have to see if philanthropy feels comfortable about selling it, you know, at a different price in other territories.
Correct. And that's what I say. Those were the controversial discussions which I referred to on pricing and on market availability. Does it have to be at the same price everywhere? Can it be lower? Can it be higher? Can you differentiate? There we'll need to see what works out. And
you should have a discussion again with day one biotech. I always forget the additional biopharmaceutical. I know Sam Blackman though, but because they decided to build their own distribution system. So for some reason, they don't want to sell their drug to bigger pharma companies.
That's what Michael, I think I heard what your name is, just indicated as well, that should be something you do. But then that doesn't solve the issue, I don't think.
No, I know.
The question is still, do you want to jack up the price, get more money and do more projects?
No, but it would be interesting to understand why they don't do it.
They don't sell their...
It's clearly in their model. They don't want to sell their drugs to bigger pharmaceutical companies. They want to build their own distribution network. I don't know why. I never pushed the discussion further with Sam, but it would be interesting to find out.
Thank you. One reason can be that you don't want to pay a tax to Roche, because this is their strong point. They have monopoly power, they have their size, and they take their, you know, even for completely non-rare diseases like COVID vaccines, Moderna decided to go its own way. So not like, contrast to BioNTech, they didn't go through Pfizer. And you see now, Pfizer is making zillions on these things where they did contribute very little.
Understand the question. We need to answer it. It depends. Everything is going to be a trade-off.
Yeah.
Do you want to go fast and do a lot of things, or do you want to do one thing on the next 30 years?
Yeah.
That's the choice that you're.
I completely agree. I just wanted to.
I'm very, and that's something. That's why I'm not only going to do this. We're going to do this with all the stakeholders, but I am hyper pragmatic on this. My child died. We're going to save these children, and we're going to move forward. And if somebody else makes a lot of money on it, I don't really care.
No, I agree with you. It's just that if we cap the possible price for the drugs, it will have an impact on how much you sell the company for. So I think that we have to crunch the numbers and see in a very pragmatic way, you know, what is more advantageous.
I agree. That's what I would do, and I would be relatively opportunistic in the sense we do what
the models,
what gets us going, right?
Yeah,
that's my indication, but that's why we need a lot of stakeholders together, and that's not going to be.
I think in this sense, the But it's the cystic fibrosis example where that capital was also sold at a very high price, too high for what was expected, since it was driven by patients. Might be a good example because they really wanted to keep the research going. This was
That's
their,
exactly that.
so it could be a good.
And it depends. I think there is not a, my personal opinion is that there's not a unique solution to it. It depends on where you're at.
Yeah.
Some people will say, ah, no, but it's great. We now have a lot of returns and we're going to take the next wave of medicines. Other people will say it's impossible that it costs 700,000 euros. It's crazy. We should not be doing it. And it will depend on your position, I think. And that's why we will need to find a balance, because we'll come back to it later on. There are a lot of stakeholders to manage. Yeah? So you've got, we've just heard philanthropy, who doesn't want to pay high prices but wants high return, and needs to get the money to get it going. We'll have the who will do everything to buy this as possible price. We have the European Commission, who doesn't want their member states to pay crazy prices, who wants a title. So there are a lot of stakeholders together around one table. It's a huge thing, yeah? But theoretically it works, I think. Because this is what it would look like. Yeah? So you bring together capital structure, 100% of the capital provided, part of it philanthropy, part of it pharmacy as part of it public money. Then you have a mezzanine layer, which carries a bit of risk, but which gets return for it based on private investors, impact investors, money which can go in there. And then there will be a fixed income debt layer, which gets a fixed return of X% per year without getting any of the equity upsides. If things go well, these guys will get a lot of return. They will get every excess return on top of what the debt provider is asking. If things go wrong, these guys will be wiped out. They will lose their money. But they don't really mind that they lose their money, because they have just saved a bunch of kids, which is their core goal. And that's why they're doing it. They're not doing it to make a lot of money. They're doing it to help the children. So who could be in those tranches? In the philanthropy session, you will recognize the beautiful logo of Kick Cancer. But there are different types of institutions. The Kick Cancer and Imagine for Margot are institutions focused on pediatric oncology. Then you, in every region, in every country, you have the cancer-specific organizations, and then one step further is the healthcare-specific organizations, and even one step further are research-specific organizations, and one step further are general well-being initiatives. So there is some money. These logos together will be 100 million euros per year. That they are collecting only in Belgium. They collect 100 million euros per year of money, which you can use to, if you do that in this structure, invest 800 million euros of new projects every year. If you would funnel all that money into this space, so that's super interesting. Again, two sides of the medal. Some people will say, but isn't philanthropy now financing the returns of the banks? Yeah, if things go wrong, we will use your money, Delphine, and give it to the bank to pay their interests, but we will also have a molecule which reaches the clinical wards. Other people will say, oh, great, I'm now getting in every euro Delphine collects, gets me 8 euros of money I can invest in oncology. So it depends on your view and what you believe in. And if we calculate it through, if you assume that public CSR and philanthropy does not need any return at all, they just want societal value, you come to a total weighted cost of capital of -5%. If you assume that public CSR and philanthropy just want their back, they don't want the return, but they just want every euro that they put in, they want the euro back, then you come to a weighted cost of capital of 2.6%. Remember, we were looking at way different numbers when we were talking about the pharmaceutical industry. And remember, this is what makes the difference. If I'm at 5%, my I3h project got financed. If I'm at 15%, which is what you would at least get, I think, if you rush, then this would be the stupidest project ever. So this is highly sensitive to the expected returns. And so that's what it should do. It creates a leverage effect on the equity-like investments. It creates a leverage, 8-fold leverage in this illustration on the money philanthropy gathers. It reduces the cost of capital, and it can be tweaked in such a way that you don't need all the money up front for all the projects, right? It can be commitments which come year after year. It can be guarantees by government. There are a lot of optimization moves here. It doesn't need to be please deposit your cash on this bank account. It's something which is spread over 10 years over the life cycle of such a development trajectory if you want to. But it does require somewhat predictable returns, and that's not what a pharma project delivers typically. Yeah? That's not what they get out of it. And so that's where the second dimension comes into place, which is this portfolio structure. That is great, super stimulating intellectual work done by Professor Lowe at MIT, by Professor Chik at INSEAD about this space. I would encourage everyone to read into it. It's magnificent. It needs to be tweaked and refined a bit here and there. There are some comments. I talked to Andrew Lowe and he agrees with the tweak, so we would love to continuously update it. But if we build a portfolio of independent projects, you can materially improve your return volatility, which is what you would need to be able to attract private capital in the structure later on, else it would not work. And then the private capital would be executed in adaptive trials. This is now I'm starting to get out of my comfort zone. I'm more on the financial side, less on the health clinical trial side. But there is academic evidence that smart trial design with adaptive trials, so trials which adjust along the way and which are using different hypotheses which are tested in the same multi-arm trial, that they generate a lot of value. And if we get these trials designed and executed by the community, by the existing ecosystem and pediatric oncology, the bad thing is that there's not a lot of money in it, but the good thing in it is that the community works together very well to get a lot of return for every euro that's invested. So if we can mobilize this community, you not only get better insights, but you also get better adoption later on. Because if your community has worked on this molecule and it works, then their hospitals will also use this drug to help the children, and there will be less of a hurdle to adopt the new molecule later on, which creates a lot of value. And then the last element to the structure, I'm going a bit quicker, is the individual SPVs. The idea would be that we design these adaptive trials around one specific focus area, one target which you want to work on, one disease area which you want to get progress in, and that all of the IP which is built is injected in this individual SPV so that it's very easy to do two things. One, to attract other stakeholders' capital. So I think that there will be, if you look at ATRT, there will be an ATRT organization of the United States who is willing to make progress on ATRT and who is willing to give a grant, not to the fund which does it on all different cancers, and I don't want money to go to leukemia, but I want it to go to ATRT. No problem. This is our ATRT SPV, and you can fund this specific SPV and get even a stake in that specific SPV if it's successful. And secondly, it's very easy to afterwards sell it or keep it as an individual economic entity where you can really monitor it and get it monetized as much as possible.
But then you talk about the disease-specific focus, or because you can have, for example, a specific gene that is that has a mutation, and where you can work from the molecular.
It's hybrid. In my initial hypothesis, it was mechanism of action based. So that's what you say, which pathway am I working on? And that mechanism of action can be used in different disease areas so that you also extend the portfolio. That is, I think, still going to be a large part of this, but based on input from oncologists, we have opened it up to target specific, which is also still molecular, but also disease specific areas, because some diseases require it apparently. But I said I'm not the healthcare specialist. This is based on oncologist inputs. We've broadened it from the mechanism of action into specific focus area. And so that works on all those levers which we set, because if we do this, we're going to reduce the cost of capital. We are going to be able to collect and attract a lot more cash into this space, which is underfunded today. But we're also going to work on the cost of the trials, because by working together with these academia, with the thought leaders in the field, you will immediately get priority on the recruitment. Each oncologist in the hospital in Boston will recommend this trial, and everyone will enroll in the trial. So you will get much better recruitment rates for your trials. You will get much better adoption rates after the trial has been done. So people will want to use the molecule because it is the state-of-the-art reference place in it. And it will improve the probability of launch because you're really working on the shared knowledge of everyone around the table in the space. And that's a bit what we would love to work on and what we would love to work out. And so what it could look like is a bit what we've designed here. So the ultimate end game is to maximize the value for the patient, increase his availability of working therapeutics. To do that, we would run these individual SPVs, which each run an adaptive trial on one specific focus area, mechanism of action, or whatever it is. These specific trials will be designed based on the shared knowledge of the academia, but also of pharma and of everyone who is involved in the space. So, but they will be guided by these experts. That's exactly what the GBM Agile trial is doing. So they brought together 130 experts from academia, from pharma, from different stakeholders, from governments, from patients to guide and design such an adaptive trial. The trial as such will be executed working together with the existing ecosystem, so no duplication of efforts, working together with the existing trial centers. And they can be funded by the current sources, the way it would be done today, the people who are interested in the field. But the new thing is that they would be, to a material extent, be funded by the pooled investment fund. The fund, if there are proceeds, get these proceeds back and can recycle the money to continue to invest in the future. But more importantly, the fund is investing in quite a few of these individual projects independent from each other, thus creating a portfolio which narrows the returns graph, which allows it to attract a lot of new capital, much more capital, like an order of magnitude bigger than what you would be getting if you would not have such a structure to invest in this and to move further. We've already discussed a bit the different economic benefits, but the main one is that you reduce the cost of capital and pool more capital into the space. So I had a few considerations, but most of you have already highlighted them. So let me pause maybe here, and now that we've ended the loop, here a bit. Any questions or concerns?
I will say a few words, and then we have some questions online.
Okay, super.
Yes, well, Sam, thank you very much for this comprehensive and quite, I would say, exciting presentation and suggestions. So we are so pleased to have with us Annette Baker, who is the CEO of the Cancer Tumor Foundation in the United States. I'm sure that she will have some comments, but my question I would say to both of you would be, obviously the European and the US ecosystems are quite different. So is this model, you think, relevant, applicable across the pond?
I would say yes, if you ask me, but I would, no, apologies. I would say yes, because and even I would go even one step further. I think the value can only be captured if it is transatlantic, and if we tap into both the scientific knowledge on both sides of the Atlantic, but also on the capital markets on both sides of the Atlantic. So I think it would be a strong plus to look at this from a global perspective. And based on the discussions so far, and those discussions include discussions with Professor Lowe at MIT in Boston, based on the discussions so far, I have seen no reasons to believe that it should not be applicable on both sides of the Atlantic. I don't know, Annette, if you want to comment on that.
Good morning. First of all, fascinating. Yes, I have been nodding the whole way through. So yes, it is absolutely globalizable.
Then if I may, another question to both of you. Obviously, and for me, this is a model which could be seriously discussed with the pharma industry, including the big pharma. So I know that Annette established good collaboration with the European Federation of Pharma Industries and Association. I was pleased to see that I3h, which was the former IMI that I was pleased to run some years ago, was on one of the slides that were presented today. So my question is, did you have a chance, perhaps first, Sam, to discuss your proposals with the big pharmas?
Yes. So over the past months, we've discussed both with pharma and we've discussed both also with IHI you refer to. Both parties are in principle enthused, but you sense that both parties will have different priorities in the execution, and thus aligning the two parties, aligning three parties, philanthropy, government being IHI in my mind, and pharma will require quite a bit of effort. But the principle as such are fully endorsed, and we've talked to Sanofi, we've talked to Roche, we've talked to Bayer, we've talked to BMS, and at IHI, there was especially at IHI, there was a warm welcome in the sense that they are committed to fight cancer, that they would really love to contribute in the fight against pediatric cancer specifically, and that today they have not yet found a lot of venues to channel money into the space, which also have a return, which also makes sense to do it. So they want to invest in it, but they have a lack of good projects to support. And IHI kind of indicated that if we come with a proposal which works, where there is a real return, they would really look into it in depth and would love to be involved if their role fits their mission.
Okay. I work at the European Innovation Council. So we invest with tickets up to 15 million. We take equity positions, and we also provide non-dilutive funding. It's a public vehicle, you probably know, it's been set up very recently. And we invest early stage around A mostly. It's really an interesting model. I think there is a lot to be done to make everything much more efficient than it is at the moment. So this special purpose vehicle makes a lot of sense. I think there are some similarities with vehicles we've seen, like the Diabetes Foundation in the US, for example, where they focus on type 1 diabetes, and they have early stage support to research, which we do as well, but they usually use philanthropic money to do this. So they support early stage research, fundamental research on type 1 diabetes, and then they support the investment part, the more commercially oriented part, because they have a venture arm. So I think there are some models there that you can look into and probably extract some information. But I think this idea of having a special vehicle focused on a disease or subfamily of diseases is very smart, because as you said, then you have the motivation to solve that particular problem, and you deploy capital in a much more smarter way than, if you are not specialized. But there are some models around that are similar. So some of the things that we do are similar. For example, we have portfolios at BAC, and so we group our projects into different groups, and then we provide fundamental research funding plus transition funding plus an investment equity. So the grant is non-dilutive, and it's not an investment, and even the investment, we understand the return, the probability of getting a return is low. So I think there are some examples already you can extrapolate. It's a good idea. I think the SPV model is a very smart idea and needs to be explored, but you can extract some ideas from existing models.
It would be great if you can have a discussion later on. Super interesting. I have not looked into it, to be honest. It'd be good. Thank you.
There's a lot to be done, honestly, because we see that. So one of the things about portfolios, they're much more efficient than deploying capital into the build startups. And every startup tries to replicate the structure. And you can see sometimes even the licensing of the IP from a university, sometimes we see a lot of time going into that. You could put everything and doing it differently, much faster. So there's a way to make everything much more efficient. So the model needs to be a bit polished, and then everybody from all ends should be proud of it. I think it's possible.
Thank you.
I'm not sure. So I think it's very nice. Thank you. Very exciting. One question, if I want to play with the David advocate. Your industry is interested. You tell them, look, you will get your return, and you will be subsidized because philanthropy and government will put even more money on this. What should we ask them? Well, we mentioned Andrew Lowe. Andrew Lowe showed that when you look at the risk-adjusted return reality, biotech is beaten by the market. Big pharma beats the market 3% a year. On top of that, he also showed that in oncology, so the FDA has this fast track for really exciting new research, and then the slow track, which is for, let's say, Me Too innovation. It shows, the team shows that they make even more money in Me Too's. So I would suggest to Big Pharma that if they want to participate in this, they need to accept the market return. Because, and by the way, it's very, very important to keep in mind what the property rights will be on these kind of things.
Correct.
Because, you know, they have the best lawyers. So how do we deal with these kind of things?
I have there are a few questions combined. I'll go back in the statements. Accepting what are we asking pharma? You're asking them the CSR money, which comes at zero return. So they will not get any return, below market practice. You're asking them to contribute to the SPVs. And what are you asking them to contribute? Resources to the community. So you want them to invest time of their thought leaders in the fields in this community. And you're also asking them to invest molecules. And that is going to be a very sensitive discussion. You sense it already in the initial discussions. Everyone is enthused until people realize that, but we also want to have a look at your IP, right? We want to use your IP and inject it into an SPV, which is outside of your control, to then develop pediatric market access, which you might want to buy back in 5 years from now. That is very sensitive to get them to do. If we can get them across that bridge, that would be, I think, major result. And then if you look at the, what was your last question?
It was still on this issue of the hurdle rate, because as they say, Me Too's are very profitable.
Yeah, I don't know how to answer that one, because you will get an exclusivity on your pediatric rights. You will get that period which you can monetize in the SPV, and afterwards, yeah, I don't. Yeah.
So, typically in pediatric oncology, Me Too drugs are complicated because some targets which are identified in medical oncology are relevant in pediatric oncology, and we have 8 alpha inhibitors, or I don't know how many N521, and so on. And when we want to translate those drugs into pediatrics, we have to find out which one can be tested, because they are all slightly different as Me Too drugs. So they created specifically for pediatric oncology, but that's now being replicated in other fields of rare pediatric diseases. The concept of strategic forum, where you have a pre-competitive discussion among the representatives of the pharma industry that do have one of those Me Too drugs, and you put them in a room together at the EMA or at the FDA, so they alternate pediatric oncology. They have about 2 meetings a year. And each representative of the industry presents their drug together with academia in pediatric oncology, and they jointly decide which should be prioritized in terms of clinical trials for children. So although you do have Me Too drugs in oncology, in pediatric oncology, we just circle around the issue with the pediatric strategic forum, where we managed to decide which drug is to be tested first. And it has become a almost industry standard to have these meetings when you want to put innovative drugs in the market, because the academia are trying to discipline themselves to make sure that if they decide that this drug is not a priority, nobody within the pediatric oncology unit should actually agree to open a trial with that drug. So that sort of balances out the problem. I don't know if I made that clearly.
I have a question.
Yes.
So the SPV is targeting a specific return. This is essentially a philanthropic layer of capital that gets the proof of principle done. So is the SPV promising LPs a return? Probably not. Is it the case?
That's the sense.
Could you repeat your question?
So the model in your mind, so the SPV, is it seeking a return?
Correct.
Or this is the initial.
No, the SPV will also include all IP in the next stage. So it will first assess the molecule and the therapeutic. It will design the trial, it will execute the trial. It will, of course, die out if there is no future. Then the SPV will be removed and no more funding will be invested in that leg. But if it is successful and there is a market access, SPV can continue to run through the different stages of progress. And the SPV, the way it's structured, because it is within an SPV, it can choose to continue to go into a market access and even build its own delivery organization, a bit to Michael's question, or it can choose to along the way, if it goes from phase 2 to phase 3 and it's so clear that it will get a market access, it can already divest at that point and monetize the IP which is built in that SPV. And that's why the SPV is good, I think, because it has pooled capital, but it also allows local investment. So if I am Roche and I have a very promising molecule on the shelf and I need to inject it in that trial, I could get a convertible bond on the SPV. And if it's my molecule which ends up to be attractive, then I get whatever equity stake. And things like that gives us so much flexibility to be able to give, again, capitalistic, because this is designed within the capitalistic scheme, but capitalistic incentives to Roche and Sanofi and the big guys to invest in the SPVs, to contribute to the SPVs.
So what we see is that fundamental research is always money losing, just by default, by definition. So it depends on which point you go in, whether you can generate a return or not. So I think you need to design for philanthropic capital. You can be honest and say, look, we're trying to solve a social problem. We probably will lose this money, but we will eventually solve the problem. And to me, even as an investor myself, as an individual, I would contribute. It's an honest, transparent impact investment fund. Then the other thing is, if you tell me the SPV will generate a return, then I'm more cautious. I want to see exactly which one you're coming in, what's the risk you're taking. So as an impact fund, I can see it immediately. The return generating part is more complicated.
I understand, but
You donate money or you invest?
So we are the government.
Yes. So do you have convertible?
So we do two things. We do convertible loans. So we do grants like we used to do. I'm not a long-term public functionary. I just came to help set up the portfolio. I'm a private sector kind of person, but I'm at the government right now. So we contribute grants, and these are no investments. And now we have an investment fund, which is our regular venture capital fund. We take equity positions up to 50 million and minority stakes, and we ask for co-investment. And the concept is a cascade kind of effect we're looking for. So we do both.
When it's successful, you sell your shares and you keep them.
Well, the commission is thinking about it. The reality is the commission just wants to spark private sector to co-invest, and the private sector.
How are you going to negotiate with pharma? Because they are a very strong position. And to me, this is a very strong point of this structure, because you have just not to one deal, but it does 50 deals over its lifetime. You have the reason to build strong team at the pooled investment fund, which manages these SPVs and which is in a position to develop its own intellectual capabilities, to understand how a licensing deal looks like, to understand how a financing agreement looks like, and you will be able to attract specific, also expensive, because that's what you say, they have the best lawyers, they have the most expensive lawyers, but you will be able to attract a handful of specific and somewhat more expensive expertise at fund level, which can then lead the negotiations with pharma, which can then make sure that we have a long-term plan in all of these SPVs to monitor the IP and to make sure that we're not leaking IP everywhere to third parties. So that's a bit why I think it's a pro in this setup.
I think it's a good idea. You could even set up a benefit corporation.
Yeah.
Make it a public sector corporation.
Yeah, correct. So these are the ones I think most of them.
In the market, in the general market, lower in fact, good.
Correct.
I'm sorry, we don't hear you.
I was just building up what my guest was saying, that the general public also has an interest in investing in companies with lower return, provided that there is a positive societal impact.
Correct. And I think the time frame is correct. It's the last bullet. These were a few considerations, and I think we've touched most of them. But what you say, Delphine, is the time to corporate social responsibility is now. Everyone is interested in it. Everyone wants to invest in it. Everyone wants to lead and be responsible as an actor. Wants to be a B Corp. Wants to show to the world that they are doing well. Public and corporate life is centered around that. So this awareness is so present that it creates opportunities for such a model, or for any model today, but for such a model to reap the benefits of it.
So, and I'm not a lawyer, I'm not a finance person, and so I'm looking forward to your input. I was thinking exactly about the same ideas, but I'm an economist, and therefore I'm always trying to anticipate unintended consequences, side effects, etc. Okay, so one thing, if you provide more public investments, philanthropy, etc., to fundamental research that was not so profitable, you also create an incentive for these companies to just exit it. Let you guys do it, and I will step in only when it becomes profitable. So the total amount of money invested need not increase. You pour a lot of money, but the complementarities are not necessarily there. And we're talking about $1 trillion market a year. So
Can I answer this?
Just finish this point. So even if you put 100 million, it's really a drop in the sea of the total amount invested. So my thought was exactly to have to make sure what Matthias was saying, to make sure that they put skin in the game, etc., that you cannot resell your IP rights. Because if you can resell them, you let them again step in later. So that your SPV, and I was using exactly the same term, your SPV would actually be forced to go up to the markets.
Yeah, okay.
And then, so and the companies would have to co-invest in the beginning, at the early stages. The SPV would be owned by also philanthropy, government, etc. So exactly for this idea of recycling the money. But then, if you did not put money in the game in the beginning, you cannot sell at the end. We are talking about illnesses where nobody invests, so the option value is 0, and now you give them an option value. And I thought that this lock-in could be a way, and that's where the law comes. The regulator should also provide market authorization for different lengths in time if it's an SPV, which is co-owned, so longer periods, and shorter periods if you're just a private company. Or is that not legal?
Well, no, that wouldn't be legal. They can make differences, but not like that. But they do make differences. For instance, the legislation on pharmaceutical products is being rediscussed now within the European Union, and they, for instance, they want to penalize the Me-Too drugs and give them shorter exclusivity on the market.
Which you cannot condition on the entity that applies.
You can only do that for reasons that are proportional and understandable. So, for instance, you can get a 1-year additional exclusivity if you put your drug on the market in every single member state. Within 2 years, if you're a big pharma, but if you're a medtech or smaller company, then you get 3 years. But you couldn't really make like a major. You have
to be 5 or 10 years.
No, and then you have to sort of build up a reasoning that makes sense. Okay, you have 1 more year when you were a biotech. You have smaller teams, and you don't as often, you have less in-house skills to do it. But The problem now, even in fundamental research, what we do see is there are no investments in rare pediatric cancers, just because careers are being built by prospects, and researchers in oncology have more prospects if they specialize in the field of a more prevalent type of cancer. And so we do see that it's extremely difficult to attract young talents, even within universities, because not everyone gets to do a postdoc after a PhD, so they have to have the opportunity to switch to pharma. And so even attracting or building pediatric oncology labs within universities is a challenge that we have identified as a roadblock for innovation in pediatric oncology. So today, the big industry, like pharmaceutical industry, doesn't invest anything in pediatric oncology at the fundamental level. So whatever philanthropy would be doing now in that field, it would only increase the pie. But I agree that we have to think about how do we make sure that we build labs in pediatric oncology within universities. I have less hopes in trying to build them within the industry.
Therefore, the idea that if you do not invest
No, I like the idea.
zero,
I
you cannot
like
make money at stage and at the end.
No, I like your idea.
And there are many flavors of the idea. I think it's a good idea, but you can give a right of first offer to everyone who was in the first stage, which is like a bit middle way. Yeah? So you can buy, you can sell, but you get the right of first offer if you've contributed to the initial capital. I mean, there are 20 flavors between just markets and what you say, which is a very narrow confined, and that's a bit. We're going to need to be pragmatic.
One quick comment. One of the things that we see in our pipeline is that the best startups we see are platform startups, where the company is not focusing on just one narrow disease, but focusing on a technology that can generate a range of treatments. And we see this as working very well with AI. I was mentioned before, then AI comes into identifying targets, molecules that bind to targets, estimating affinities. All that can be automated now. It's a huge opportunity. If you focus very narrowly, there's a challenge because you need to convince the market, the risk is very high, but you focus on a platform, on a machine that develops therapies that can go to pediatrics. I think it's much more viable. We are investing a lot in this. I'm focusing all my attention on platforms.
I think it would be at group level at pooled investments. There you have the platform thinking, which understands those technologies which you're referring to. And then at SPV level, each individual SPV would be focused on one focus area, it's called, but it could be a specific technology. It could be something which you use to cure a specific therapeutic. So there's already platform thinking embedded in that SPV, but it would be super cool to hear what you're doing.
Some biotech investors in the private sector focus very much on platforms. This wasn't really invented by us at all. We just observed that was smart. And then the wave of AI and mapping, RNA, DNA, epigenomics, all that mapping is available. Robotics is available. AI is available. The opportunity is there for the platform.
Agree.
Yeah, we have 1 minute left, but
Okay.
maybe the next question. Annette?
Hi, good afternoon, everybody. Can you hear me?
Yes.
Okay, so first of all, this is fascinating and very much in line with what we're trying to do at the Children's Tumor Foundation. What is interesting, and I think you made a very good point, Sam, about the fact that you want to be attractive to pharma, pharma wants cheap dates, right? They want to know very quickly, does this drug have legs, yes or no? And I think the idea of platform trials is absolutely, I think, the way to go, the way you presented it. What I would like to do here is maybe make a little pitch, because on April 25, we will be presenting the platform trial for rare disease, which is called, it's an EU Pearl, it's an I3h project. And I think what I'm seeing between pediatric and rare disease, we've been working for quite a while now with the Cure Pediatric Cancer Foundation that Sam Blackman is also involved in. And what we have seen over the years is that there's a huge overlap between rare disease and pediatric cancer. Too few patients, need for multi-center trials, not a lot of money to be made. I mean, all the identical same things. So I think we can benefit a lot from working together. The model that I could invite you maybe to look at, and we've been looking at it, is LifeArc. It's a UK-based investment system, and they've done some really cool stuff. So that would be something that I would definitely look into. But yeah, I like what you guys are doing. I have been talking a lot to pharma and to investors. The ESG or CSR is indeed very in, but to be honest, it stinks. Everybody tries to walk around it with a big smile on their face, you know. So we need to figure out a way to get the public enthused about ESG and CSR. I think we still have some work to do because everybody agrees that this is where the money should come from, but it's still hard to know who is actually responsible in these major pharmaceutical companies. And then the last point I wanted to make is, let's not overlook biotech. We know the investment world, I heard last week, is in what they call a nuclear winter, which means there is no money, and they're extremely risk averse. So the biotechs are in a very tough spot. So maybe this could be an opportunity for you to save the really good biotechs with the system you're setting up. And then my last point is, let's keep it simple, right? Let's create a few examples for pharma to see that we can do it. And then I think the money will come. I'm pretty sure about that.
Thank you. Well, I would say concluding remarks is I'm very grateful to Sam for presenting the work, for Delphine for setting up the center, obviously. And I think this was actually what the I3h Institute aimed for by inviting Sam. This model, well, you're working specifically on pediatric oncology, but we discussed this. This has such a great, I think, potential that is definitely worth exploring with, well, economists together with scientists, life scientists, sorry, Michael is looking at me. So thank you to all of those who were present online. Thank you again for being with us. And we're looking forward to further collaborations. Thank you. Bye.
Thank you.